This video is brought to you by Global Men's Wellness, your 24/7 AI health expert. No copays, waiting rooms, or awkward conversations. Just real answers whenever you need them. Visit globalmenswellness.com to try it free and get your own on-demand concierge-level wellness expert today.
Welcome to the 21st Century Man podcast, where our mission is to take a deep dive, chapter by chapter, into a truly invaluable resource, the book, The 21st Century Man.
Yeah, this book really is something else. It tackles topics, really crucial stuff for men's health and well-being, and it does it with a directness you don't often find.
Absolutely. It cuts through the noise, gets right to the expert-backed facts.
Ah.
And today, well, we're turning the page to chapter 91. This section digs into a condition many men, especially over a certain age, might face, but it's surprisingly under-discussed. We're talking about Peyronie's disease.
Right, and it's a topic that needs a sensitive approach. Dr. Judson Brandeis, a urologist, wrote this chapter, and he brings exactly that sensitivity plus that essential clinical view.
So our goal for this deep dive is to really unpack everything this chapter puts on the table.
Sure.
What is Peyronie's disease exactly? What does the source tell us about how common it is, how it tends to progress? What are the potential causes? And crucially, what treatments are laid out in this expert material? It's all about arming you, the listener, with that core knowledge, understanding the maybe surprising facts, and just appreciating the seriousness in the management options based directly on what's in this chapter.
Exactly. Getting informed, but in a way that's thorough and understandable, taking what can be pretty complex medical info and making it accessible.
Okay, let's get into it then. This is a fascinating topic, even if it's a challenging one. Chapter 91 starts right out defining Peyronie's disease. So what is this condition, fundamentally, according to the source?
Fundamentally, Peyronie's disease is described as an acquired disorder. And that acquired part, it's key. It means it develops during your life. It's not something you're typically born with. The main issue is the formation of abnormal scar tissue.
Scar tissue.
Okay.
And this scar tissue forms specifically where?
It's on the inner lining of the penis. The chapter is quite specific, actually. It uses figure 91.1 to illustrate. It forms on a structure called the tunica albuginea.
Ah, the tunica albuginea. That sounds familiar. That's the tough fibrous sheath, isn't it? The one that wraps around the erectile bodies.
That's the one, yeah. Think about an erection, the penis gets rigid because those erectile bodies, the corpora cavernosa, they fill up with blood. Well, the tunica albuginea is like this strong but usually flexible casing that holds that blood pressure in, letting the penis get firm and long.
Got it.
In Peyronie's disease, this scar tissue forms within or on that tunica albuginea.
So, okay, when the penis tries to get erect, tries to fill with blood, this bit of scar tissue, the chapter calls it a fibrous plaque, right? It just doesn't act like the healthy, elastic tissue around it.
That scar tissue, it's inelastic. It doesn't stretch. So while the rest of the tunica and the erectile tissue are expanding and lengthening, this stiff, scarred spot just holds back. It restricts that expansion. And the result, as the chapter explains it, is penile deformity, pain, and for quite a few men, associated erectile dysfunction, or ED.
And the deformity we usually see is a bend, a curvature.
Yes, that's the most common presentation. Because the plaque is usually just on one side, or in one location. It causes the penis to bend, usually towards that plaque during an erection.
Okay.
But, it can also show up as indentations, sometimes called hourglass deformities, or even shortening or other changes in shape. The chapter mentions this plaque is made up of excessive collagen, the protein that makes up connective tissue.
Right.
And over time, these plaques can actually get harder, less flexible, and some even calcify, turn almost bone-like, which obviously makes the problem even worse.
Wow, calcified scar tissue. That's quite an image. And the chapter, it starts with that John Legend lyric, "Love your curves and all your edges," which, thinking about this condition, feels really poignant. Sets a compassionate tone, doesn't it?
It really does. It acknowledges the physical changes, and the emotional side of things too. Frames it with some self-acceptance, but also, importantly, opens the door to talking about treatments, which is vital.
Speaking of impact, let's look at the numbers. The chapter gives us some pretty important stats on how common this is and, how it usually plays out. What does the source say about prevalence? How many men are we talking about?
The chapter states that Peyronie's disease affects approximately 5% of men over the age of 40.
5%. Let's just pause there. 1 in 20 men over 40.
Yeah.
That's not some rare thing. That's a significant number of men potentially dealing with this.
It's a substantial number, yeah. which really underlines why this is such an important topic for the 21st century man. And the chapter gives crucial info about its natural course, too. Someone might hope it's temporary, that it'll just sort itself out.
Right, you hope it just goes away.
But the statistics in the source are, well, they're quite sobering. It only resolves spontaneously, just goes away on its own in a little more than 10% of cases.
Only about 1 in 10 men will see it get better without doing anything.
That's what the chapter says. Yeah, so the vast majority won't see it just disappear. And the news gets a bit more concerning, actually. Nearly half, almost 50% of patients will see their deformity get worse over about a year.
Worse. Wow.
Yeah. The chapter explicitly states that untreated, it improves in only 12% of men.
Okay, so let's break that down. If you don't treat it, it either stays the same, which isn't great if you've got pain or a significant bend, or it actually gets worse for almost half of men. And only a tiny fraction, like 12%, see it improve on its own. That really hammers home the point the chapter makes about not waiting, doesn't it?
It really does. The potential for it to get significantly worse for so many men means that a wait-and-see approach, well, it's often not advisable, according to this expert source. That's why the chapter strongly encourages patients to start treatment as soon as possible once they're diagnosed. Early intervention, based on these numbers, it seems critical to potentially stop it from getting worse or maybe get better outcomes.
And the impact isn't just the physical stuff, right? The chapter mentions quality of life.
Oh, absolutely. The source material describes Peyronie's as potentially physically and psychologically disabling. It can significantly lower a man's quality of life if the curvature is really severe or if there are problems with rigidity because of the plaque. Penetrative intercourse can become difficult, sometimes even impossible.
Which naturally has a huge impact on intimacy, on relationships, on a man's self-esteem. It hits a very personal part of life.
It does. And the psychological toll can be immense. You're dealing with the physical changes, maybe pain, the worry about sexual function, and just the uncertainty of how it's all going to progress.
Okay, so we've got the definition, the numbers, the potential impact.
Yeah.
But what causes it? Is there like a single thing that triggers it?
This is where the source material has a really surprising fact, actually. While we often think of trauma as the cause, the chapter notes that, interestingly, at least 4 out of 5 men with Peyronie's disease do not remember any specific event that caused it.
4 out of 5. That's 80%. So that common idea that it's always caused by some big injury you'd remember, that's just not true for most guys, according to this book.
That's what the statistics in this chapter point to. It suggests that while trauma can be a trigger, and we're going to talk about a pretty dramatic example in a minute, it's not the remembered start for the majority, which kind of points towards maybe other underlying factors or perhaps microtraumas, little bumps or stresses that you don't even notice or recall.
So what does the chapter list as these other potential underlying causes or things it's associated with?
Right. The source material lists several conditions that are statistically linked to Peyronie's. These suggest maybe a systemic predisposition or some underlying issue with connective tissue. One of the most notable links mentioned is with Dupuytren's contractures of the hand.
Dupuytren's contractures, I think I've heard of that. But what is it exactly, and how on earth could it be linked to Peyronie's?
Well, Dupuytren's contracture is another condition where abnormal thickened tissue forms, but this time it's typically in the palm of the hand. It can cause the fingers, often the ring and little finger, to kind of curl inwards towards the palm. Sometimes they get stuck like that.
Oh, okay.
Now, the chapter points out that Dupuytren's is known to involve abnormal collagen deposition, just like Peyronie's, and it often runs in families, suggesting a genetic link. So the association between these two conditions hints that some men might have sort of a systemic issue with how their body makes or handles collagen or connective tissue. This could make them prone to getting these fibrous plaques, not just in the hand, but also in the penis.
That's fascinating. It really shows how things in different parts of the body, seemingly unrelated, can actually be connected by some underlying biology, like a genetic tendency for certain tissue changes.
It's a great example of how interconnected the body is, yeah. And it offers a potential explanation for those cases where there's no big trauma remembered. Maybe it's a genetic predisposition plus some minor unnoticed stresses over time that lead to the plaque. The chapter also lists other associated conditions. A history of genital trauma, even if not one big event, a history of prostate surgery and diabetes. These conditions can all affect tissue health, blood flow, healing processes, potentially playing a role in developing Peyronie's.
You mentioned genital trauma, and that brings me to a specific and frankly quite alarming part of the chapter, the caution box, about the risk of penile fracture. It might not be the most common cause based on recall, but it's certainly a dramatic one with serious consequences.
It is, and the fact that the chapter puts this in a special caution box really emphasizes how severe it is and why awareness is important. Even though 80% of men with Peyronie's don't recall specific trauma, a penile fracture is a direct acute trauma that, according to the source, very frequently leads to Peyronie's disease later on.
So what exactly is a penile fracture? What does the expert source say happens?
The chapter defines it very clearly. It's a rupture, a tear, in the tunica albuginea, that tough outer casing we've been talking about. When that casing tears, while the penis is erect and filled with blood, the blood from the erectile bodies basically oozes out through that tear into the surrounding tissues. It's a structural failure.
And how does this usually happen? The chapter gives some context, right?
It's quite explicit, yeah. It typically happens during aggressive intercourse.
Right.
And it highlights a specific scenario, particularly in positions where the woman is on top, described as being in extreme circumstances. In that position, if the penis is forcefully bent, say against the partner's pubic bone or perineum while it's fully rigid, the pressure can just be too much, and it can cause that tear in the tunica.
Wow. That sounds incredibly painful and honestly terrifying. What are the immediate signs? If something like that happens, what would someone notice?
The classic signs described in the chapter are immediate and dramatic. You might actually hear a distinct snap or pop sound when the injury happens, then a sudden, very rapid loss of the erection. Followed quickly by significant swelling and discoloration, the penis becomes black and blue. It's often described as looking like an eggplant because of the shape and color.
An eggplant deformity.
Okay.
And if someone experiences those symptoms, hearing a snap, losing the erection fast, seeing that swelling and bruising, what does the chapter say they absolutely need to do?
Immediate medical attention, no question. The chapter stresses you need to get treatment at the nearest urologist or emergency room as soon as possible. This is a surgical emergency. Prompt repair is needed to fix the tear and minimize long-term damage.
And the direct link back to Peyronie's from this kind of event.
This is exactly why it's in this chapter. The source material states that a penile fracture frequently results in scar tissue forming during the healing process. And as we've established, scar tissue on the tunica albuginea is the direct cause of Peyronie's disease, leading to both shortening and curvature down the line. So while it might not be the cause most men remember, an acute injury like a fracture is a very clear pathway to developing the condition.
That's a really stark, vital piece of information.
Yeah.
A dramatic example of how trauma can definitely cause the condition in some cases. And it highlights why getting immediate care for that kind of injury is so critical, not just for the immediate repair, but also to potentially lessen the long-term risk of Peyronie's.
A powerful illustration, yeah. Injury, scar tissue, Peyronie is a clear connection in that scenario.
Okay, so whether it's caused by trauma or maybe these other underlying factors, let's talk symptoms. What would a man actually experience that might make him think, maybe this is Peyronie's? What should someone look out for?
Right, as the chapter emphasizes, the symptoms are most obvious when the penis is erect. That's key. The main things to look for include penile pain, especially pain with erections. That's often an early sign. You might also actually be able to feel a nodule or plaque. The scar tissue itself can sometimes be felt as a hard lump or a thickened area under the skin.
So you might feel the scar tissue even when it's not erect.
Sometimes, yeah, you might feel a firm spot. But the effects of the plaque, the change that it causes, those are most apparent when you have rigidity. So during an erection, besides the pain, you'd look for changes in shape. Maybe an indentation, a definite curvature or bend, some other kind of deformity, or even noticing that the penis seems shorter than it used to be during erection.
Okay.
And sexual dysfunction is also very common, often directly because these physical changes make penetration difficult, painful, or sometimes just impossible.
And I imagine the severity can really vary from guy to guy.
Oh, absolutely. The chapter notes that, some men might just have a mild curve that doesn't bother them much, while others can develop really severe, complex bends. And if that's combined with issues getting or maintaining rigidity, well, it can make penetrative intercourse completely impossible. This range in severity is why the impact on quality of life we talked about earlier can vary so much too.
So seeing changes in the shape of your erection, feeling pain, noticing a lump you can feel, especially when erect, those are the key signs. And given those stats about progression, the chance of it getting worse, paying attention and getting checked out early seems really crucial.
It is. As the chapter keeps emphasizing, getting diagnosed early allows you to consider those early intervention strategies. And based on the data presented, that's strongly recommended over just waiting it out.
All right, we've covered what it is, who gets it, how it progresses, the potential causes, including that scary fracture risk, and the key symptoms. Now let's dive into what the chapter says about treatment. This is where the book gets really practical, offering those expert insights.
It does. The chapter outlines a few different approaches for management and treatment, starting with medical options.
So pills. Is there an effective oral medication you can take for this?
Well, according to the source, the only oral medication that has shown some efficacy specifically for Peyronie's disease is called pentoxifylline. The chapter is very specific about the dosage that was studied, 400 milligrams taken 3 times a day.
That's very precise. Does the chapter explain why pentoxifylline might help? Like, what's it supposed to be doing?
Yes, it connects it back to experimental evidence. The chapter explains that in animal studies, pentoxifylline showed effects like decreasing fibrosis, that's the scar tissue formation, preventing collagen deposition, and reducing calcification.
Ah, okay. So because the plaque is this excessive collagen that can calcify, this drug is thought to interfere with those exact processes that are causing the problem.
That seems to be the reasoning presented in the chapter, yeah, based on that experimental data. It's important, though, that the source qualifies it by saying it shows some efficacy. That suggests it's probably not a miracle cure, but it might offer some benefit, maybe particularly in the earlier active phase of the disease, when there's still inflammation and tissue changes happening.
What about other pills or supplements that people might see advertised or hear about? The chapter's pretty direct about things that are not helpful, isn't it?
It is, yeah, and that's valuable. It tries to cut through some potential misinformation by stating clearly that studies show other oral medications sometimes used for this, like colchicine and tamoxifen, have not actually been found helpful.
Okay.
Similarly, it lists common supplements people might try, like vitamin E, P-BAE, that's para-aminobenzoic acid or carnitine, and states they are not found helpful according to the research cited in this chapter.
That's incredibly useful for the listener. It helps sort the wheat from the chaff, so to speak. Distinguishes between something with at least some potential evidence, even if limited, and others that studies haven't backed up. Could save men time, money, maybe false hope.
Exactly. The actionable takeaway here is pretty clear. If you're in that active phase, experiencing pain and a changing curve, talking to your doctor about pentoxifylline is an option presented by this expert source. But be wary of those other oral remedies mentioned as unproven or unhelpful.
Okay, so moving beyond pills. What about injecting medication right into the scar tissue plaque itself? Is that something the chapter discusses?
Yes, injections are a key treatment approach discussed. The chapter mentions that injections have definitely been explored, but just like the oral meds, not everything injected works equally well. It specifically notes that substances like verapamil and interferon, which are sometimes used, have shown only minimal benefit according to the source material.
So they aren't highlighted as the go-to injected treatments. Is there a specific injection that is FDA approved for Peyronie's?
Yes, there is, and the chapter highlights this one prominently. It's called Xiaflex. Xiaflex contains an enzyme called collagenase, and it's presented as the FDA-approved injectable treatment, specifically for men who have stable Peyronie's disease.
Stable disease,
Yeah.
meaning the pain has settled down and the curvature isn't getting any worse.
Exactly. Once that active inflammatory phase is over and the physical deformity, the bend, is kind of set, that's when Xiaflex can be considered to try and actually improve the curvature.
And how does Xiaflex work? What does collagenase do?
Well, the name gives it away. Collagenase is an enzyme that degrades or breaks down collagen. Remember, the plaque is made of excessive abnormal collagen. So the idea is you inject this enzyme directly into the plaque to try and break down that tough, fibrous, inelastic tissue. Hopefully that reduces the pull that's causing the penis to bend.
Right, targeting the problem material directly.
Yeah.
And what's the treatment course like with Xiaflex? Is it just one shot?
No, it's definitely not just one shot. It's a structured protocol, multiple injections spread out over a period of time. The chapter describes a typical course involving somewhere between 6 to 10 injections in total.
Okay.
And these injections are delivered in pairs. So you get 2 injections about 3 days apart. Then you wait 6 weeks before you get the next pair of injections. And this cycle repeats until the whole course is done.
Wow. Okay, 6 to 10 injections, given in pairs, 6 weeks apart. That sounds like a pretty significant time commitment spread over several months. Are there downsides mentioned in the chapter for Xiaflex?
Yes, the chapter notes 2 main ones. First, the cost. The medication itself can be quite expensive. The second major downside is the required abstinence from sexual intercourse. Men getting Ciaflex treatment are advised not to have intercourse for 4 weeks after each pair of injections.
4 weeks after each pair. And there could be, what, 3 to 5 pairs, depending on the total number. That adds up to a long time needing to abstain during the treatment period. That's a really practical thing for men and their partners to think about.
It absolutely is a factor that needs careful discussion. As for the results, what can you expect? The chapter states that Ciaflex treatment typically results in mild to moderate improvement in the curvature. So it's not usually going to make it perfectly straight, but it can lead to a meaningful reduction in the bend for some men.
Okay, mild to moderate improvement. Is there anything else the chapter suggests doing alongside Ciaflex to maybe boost the results?
Yes, actually. This is presented as a specific actionable takeaway. The chapter recommends using a Restore X device in conjunction with the Ciaflex injections.
A Restore X device. This sounds like it relates to another type of treatment mentioned in the chapter.
It leads right into the next category discussed, which is therapies. While the chapter doesn't go into huge detail about the Restore X device itself, recommending it alongside Ciaflex strongly implies it's a form of penile traction therapy, which the chapter does discuss next. The expert view here seems to be that combining the chemical breakdown of the plaque from Ciaflex with the mechanical stretching force from traction might give better results than using either one on its own.
Okay, that makes sense. So let's talk about that therapy category then. What does the chapter say about penile traction therapy and also something called shockwave therapy?
Right, so it mentions shockwave therapy first, describing it as an investigational treatment for Peyronies.
Investigational.
Mm-hmm.
So maybe not as established as Ciaflex. What have studies shown about it, according to this source?
The chapter says that in some patients, shockwave therapy has shown improvement in both the size of the plaque itself and the degree of curvature. And importantly, it's also been documented to reduce the pain associated with the condition.
Okay, reducing pain is definitely a plus.
Yeah. The source describes shockwave therapy overall as a promising treatment with minimal side effects that seems to help a subset of patients.
Promising, helps some people, minimal side effects. That sounds like something worth looking into for certain individuals, right? Maybe for those who aren't candidates for injections or prefer something less invasive.
It seems to present it as another potential tool in the box, yes. And then, as we were saying, there's penile traction therapy.
Is traction something you'd typically use all by itself?
Based on how the chapter frames it, it seems more like an add-on therapy. It states that when penile traction therapy is used in conjunction with other medical management, specifically mentioning Ciaflex or shockwave therapy, it has shown additional benefit.
So, using it alongside the injections or shockwaves gives better results than just the injections or shockwaves alone.
That's what the chapter suggests, yes. The therapy involves applying tension or stretch to the penis, probably using a device like the Restore X mentioned earlier. The idea is to physically stretch the tissues, maybe counteract the pull of that scar tissue, or perhaps even help remodel it over time when combined with treatments that are breaking down the plaque.
So the physical stretching plus the other treatments targeting the scar tissue might work together to reduce the bend or maybe help maintain length.
That appears to be the implied mechanism, and the reason the chapter reports that additional benefit when it's combined with other approaches.
Okay, we've covered pills, injections, and these therapies. What about the last resort, surgery? When does the chapter say surgery comes into play?
Surgical options are generally considered for men who have a deformity, like a really significant curve or shortening that's compromising their sexual function, making intercourse difficult or maybe impossible. The chapter adds a time factor, too. Surgery is typically reserved for cases where the deformity has been present and stable and not changing for more than 12 months.
So surgery is usually for the...
Yes, and it's a big one for patients to consider. The chapter notes that surgery for Peyronie's disease usually results in a penis that is shorter.
Shorter. You mean shorter than it was before the disease started, or shorter than it is even with a curve?
Generally shorter than it was before the disease began, and potentially, even slightly shorter than it might be with the deformity present before surgery. The scar tissue itself often causes some shortening, and the surgical techniques used to straighten the penis. They often involve procedures that either don't restore the length lost to the disease, or might even slightly reduce length further as part of the straightening process. It's presented as a trade-off. You get straightening, but often at the cost of some length.
That is a really crucial piece of information for any man thinking about this path. And how do patients typically feel after the surgery? Are they generally satisfied?
The chapter describes patient satisfaction after surgery for Peyronie's as moderate,
Moderate.
which suggests that while the main goal, straightening, is often achieved and leads to functional improvement, it doesn't necessarily mean everyone is completely happy. Maybe because of residual issues like the shortening we just discussed, or perhaps changes in sensation, or maybe still having a mild curve.
So it can be effective for fixing a severe bend, but it comes with significant trade-offs, like length, and doesn't guarantee a perfect return to how things were before, or complete satisfaction for every single person.
It's definitely a complex decision, yeah. And the chapter provides that kind of nuanced perspective on the potential outcomes.
That's a really thorough look at the treatment landscape presented in this chapter, from oral meds that might help a bit, to targeted injections, add-on therapies, and finally surgery with its own pros and cons. It's clear there are options, but they each have their place, their timing, their downsides. Really highlights why talking to a urologist who knows this condition well is so important.
Absolutely. It underscores that you really need a tailored approach. It depends on the individual, the stage of their disease, how severe it is, and what their goals are.
Now, the chapter wraps up with a key takeaways section, which is super helpful for boiling down the most critical points. Let's just quickly run through those bullet points from the source because they really capture the essence of what we've discussed.
Yeah, good idea. The first takeaway just reinforces the definition. Peyronie's disease is an acquired disorder, causes scar tissue on the penis lining, resulting in curvature, pain, and shortening.
Got it. Concise and clear.
Second, it repeats that point about the natural course. Peyronie's only resolve spontaneously in about 10% of cases.
Right, emphasizing why treatment is often necessary.
The third takeaway covers the oral medication. The only one showing some efficacy is pentoxifylline, 400 milligrams 3 times a day.
Clear guidance there from the source.
Fourth point is about the injections. Ciaflex injection is described as expensive, needs long periods of abstinence, but it is FDA approved for stable disease, provides mild to moderate improvement, and crucially it adds, make sure that you use a RestoreX device in conjunction with Ciaflex.
Okay, so combining the injection with traction, as recommended in the chapter, for potentially better outcomes.
And then the fifth and final takeaway touches on the other therapy. Shockwave therapy is noted as a promising treatment, minimal side effects, seems to help a subset of patients.
Those 5 points really do nail the essential knowledge from Chapter 91. They give you a solid foundation for understanding the condition and the treatments discussed in this expert material.
They really do. And you know, this chapter, like a whole 21st Century Man book, just provides such expert, practical insights into these sometimes complex, sometimes sensitive men's health topics. It offers clarity and really empowers readers with knowledge.
So we've taken a really thorough deep dive into Chapter 91 of the 21st Century Man, exploring Peyronie's disease from what it is, how common it is, how it progresses, potential causes, including that dramatic fracture risk, the symptoms, and the whole range of treatment strategies laid out in the source material. We've seen why early diagnosis matters, the nuances of the different treatments, meds, injections, therapies, surgery, and the potential physical and psychological weight of this condition.
It's definitely a testament to the book's value, tackling important topics like this with such clarity and expert guidance. For you, the listener, if this kind of detailed, expert-backed information on men's health is what you're looking for, we really do encourage you to check out the 21st Century Man book itself. Every chapter is basically a deep dive into something crucial.
It really is. And just thinking about everything we've discussed on Peyronie's, the prevalence being higher than you might think, the way it progresses, often getting worse, that potential link to a systemic issue like a collagen disorder, the stark risk from a fracture, and then the complexities of treatment where you might trade straightening for length. What's really striking is how something rooted in essentially microscopic scar tissue can have such a massive, far-reaching impact on a man's life. It affects not just physical function, but those deeply personal areas of identity, intimacy, emotional well-being.
It really underscores that intricate link between what seems like an isolated physical issue and a person's whole quality of life. And maybe it prompts us to think about the resilience needed when you face health challenges that touch such fundamental parts of, well, being a man. It certainly highlights why open conversation and seeking help when you need it are so important.
Absolutely. And this chapter gives that vital starting point for those conversations with doctors. Well, thank you for joining us for this deep dive into Chapter 91. There is so much more to explore in the 21st Century Man.
Yeah, it's been really informative.
Join us next time on the 21st Century Man podcast as we turn the page again, this time to Chapter 92, where we'll be taking a deep dive into the topic of circumcision.
Take control of your health anytime, anywhere. Visit globalmenswellness.com and start your free trial today. Get expert-level answers in seconds, not weeks, without the cost, the wait, or the awkward conversations. Real support on your terms. Visit globalmenswellness.com now.